Okay, so this is part two of a brief, we'll say brief history of U.S. healthcare. This was originally meant to be a one-part series, but didn't turn out as brief as we thought it would. Just to recap, maybe, I'm going to be simplifying things. There's nothing more interesting and dramatic and complex than history. So in order to talk about it, you have to, by definition, simplify things. I hope that's okay. I'll try to go as much in chronological order as possible. I'll probably hop around years, but not hop around decades. And threads that are going through this entire narrative are scientific developments or technological developments, what private companies are doing, what the government institutions or the public is doing, and also world events that affect things. Brief recap of last session. So basically before 1870, you were shit out of luck. There was nothing you could do to live past, not true, but nothing you could do to live past the average age of 35 on average. And that was true from 1860 to negative 1860, as far as we know. But then a whole bunch of things happened, largely scientific breakthroughs, the discovery of bacteria, the discovery of vaccines, lots of cool stuff happened that really pushed the average age and therefore average health up.
The asterisk with that, though, is the infant fatality, right? The childbirth deaths, that's why the number was so low, or is that?
Well, a big asterisk of why the average age was 35, big part of that was infant mortality, although even if you factor in infant mortality, it was about 42. Yeah. But from, I think basically from like 1885 to 1910, infant mortality halved, maternal mortality halved. So that definitely was a huge contributor for sure. Yeah, up until relatively recently, either being a child being born or having a child being born were some of the most dangerous things you could do outside of war. And so in the kind of if you build it, they will come aspect, so science made these developments. The private market reacted to them very quickly. Despite a common narrative, the kind of the first health insurances or proto-insurances were companies and their employees. They're not recognizable as what we would call insurance today, but the first institution that took care of someone's health on a not, one-off basis were employers. Eventually the government stepped in, started regulating things, and that kind of brought us to world events. So world events obviously screwed around with things, as they tend to do. They also forced specific types of innovation. So before the wars, you had a lot of curing childhood disease. You had a lot of vaccinations. You had a lot of peacetime developments. During the wars, we learned how to mass produce antibiotics. We learned how to do blood transfusions, things that kind of matter a lot in the trenches. A nice result of this is a lot of our technologies are developed in pursuit of better ways to kill each other, but they tend to have good side effects. So for instance, the mass production of antibiotics and the mass production, we'll say, of blood transfusions meant that starting around 1920, for the first time in history, a hospital was not a place you went to die, but a place you went to get better. Again, this is all relatively recent in human history. And then obviously between wars, we had depressions, and depressions incentivize not technological change, but policy change, right? So the government's trying to figure out how do we get people who have no money to spend money that they don't have on healthcare, which is a nut we still haven't yet cracked, but that's again, you'll see a recurring theme in how the government gets involved. It's mostly, honestly, the tone was mostly set during the Great Depression. The government's only especially concerned with people who don't have it for most of the time. Questions about the lightning review that we just did of the first half of this class? All right. So coming up are basically 1950 onward. and it has a very different characteristic. Each of these, that's why I divided them into 4, because each has very different characteristics. So we'll go to part 3 is flush and rush. So flush being flush with cash and also flushing that cash down the toilet, and rush meaning very rapid growth and also gold rushing for medical professionals. There you go. So 1950s, we have the advantage in the United States of being the only ones left standing, more or less, as far as great powers are concerned, which means that we're making all the money. Because we're the only ones left standing, it basically ensures our superpowerdom for the next, well, it's an arguable number, but the next 40 years, we'll say. Because we have all this money, both individually and as a government, we invest tons of money into healthcare infrastructure, to medical research, to medical education, improving universities. If you remember from the last session, really the concept of a medical school as we know it today was a result of the Flexner report from 1910. So again, think in terms of context here. Medical schools as a non-quackery producing institution are only about 40 years old. That's not very long at all. There are people with medical degrees who went to one of those schools and who didn't, practicing in the same market. That's how recent it is. Another interesting development is during World War II, we talked about this last time, there was a wage freeze. Right? So the government said to businesses, you can't offer higher wages to people to attract them to work for you. There's a labor shortage, and when there's a shortage, free market dictates that people are going to, there's a higher price for the thing, but the government didn't want that to happen because that would increase inflation and it would do lots of bad things. So the government said you can't jack up your payroll. But what they did say is, we will let you pay people's health insurance premiums without having that count as taxable income. So basically, it's a way of, if I pay $10,000 of your health insurance premiums, you're getting a $10,000 raise, but we don't report it as such. So that was a temporary wartime feature, I think in 1946 or so, maybe 48. And in 1954, with the Revenue Act, they made that permanent. Not entirely sure why, from a policy standpoint, they made that permanent. Partially because at this point in time, health insurance was relatively low, so it was kind of a small bone to throw to businesses and to individuals. And as a general rule, when you give something to a population, it's very hard to take it back after you've given to them. But as healthcare costs have grown, at this point, that one decision in 1954 cost the government about $280 billion in revenue, which is, for reference, a third of our national deficit is from that one decision right there. And because money is everywhere, fee-for-service is back. And if you remember, fee-for-service is, if there's something wrong with you, you go to the doctor, they do 10 things to you and they charge you for those 10 things. And each thing has a line item. Because we're not terribly worried about money, that's fine. That's a good method, or at least it's a simple method when funds are everywhere. So that comes back. Because there's this government investment in infrastructure and research and education, there's all of a sudden a shortage in medical professionals. So we have all these people. We have baby boomers about 10 years into the baby boomer period, and we have this great need for doctors. And again, there's no more wage freezes now, so a small supply of doctors creates a big demand for doctors, and the ones that currently exist get paid a lot. This is where the origin of doctors getting paid a crap ton of money starts. Before here, wasn't really a thing. I mean, doctors got paid because they did a thing for people that people wanted done, but they weren't making hand over fist. An interesting development here is for basically the first time, we've started to regulate the pharmaceutical industry. There was kind of the initial regulation of, I don't, if you remember, in 1910, basically the first pharmaceutical that we would call a pharmaceutical was brought to market. That was a syphilis treatment. And, you know, the government created the what became the FDA to make sure this stuff was safe, which is great. And again, for context, that was 1910. This is 1962. Again, drugs as a concept other than snake oil have not been around very long. Like, because we were all born into it, it seems like it's been that way forever. Certainly hasn't. So anyway, there's the Harris-Kefauver drug amendment. And this was a big overhaul. And the reason, the impetus behind this was I don't know if anybody's familiar with the thalidomide crisis. This was largely contained to Europe in the late 50s. But basically, there's this drug called thalidomide, and it was purported to do several things, one of which was it helped alleviate morning sickness in pregnant individuals. And it apparently did that, but what it also did was create massive birth defects. And about 2,000 children were born with such bad deformities that they died, and about 10,000 were born and lived with massive deformities. Again, most of this is in Europe. The U.S. actually did a pretty good job of keeping that drug out of the United States. It was never approved, despite like lots of pressure to approve it. But what the Harris-Kefauver amendment did, it did a few things. First thing was, the FDA precursor, it only said that drugs can't be harmful. It's a pretty low bar, right? It doesn't say that drugs have to actually do the thing they say they do. That wasn't a thing until this amendment was passed. So basically, the very concept of drug approval, where you have to go through clinical trials and you have to show that it has an efficacy of higher than, you know, statistical probability and all that fun stuff, more or less started in 62, at least in the U.S., with the passage of this amendment. It did a few other things. It made it a little bit easier for generics to be passed. Because basically when a patent ran out, all they would do is like take the exact same formula, give it a different name, and basically get another 20 years or whatever of patented technology. So it really blocked generics from entering the market, which again increases costs. It did some other stuff. There's some very dark history of drug trials being done on people who don't know that drug trials were being done on them, disproportionately minority ethnic individuals. This got rid of that, and it said that in order to participate in a drug trial, you have to have informed consent by all the participants. Otherwise, you're in very big trouble. And some other stuff happened. But again, that's one of the many legislations that we've gone over in this series that really very much affects everyone's life, but nobody's ever heard of. What else? Contraceptives really kicked into high gear here. The first oral contraceptive was approved in 1960, and somewhat lagging. You had Griswold versus Connecticut pass the Supreme Court saying that it was legal to take contraceptives. Which is an interesting thing. Of course, in some states, it was only legal for married women to take contraceptives, and it was illegal to distribute or have them take single individuals take contraceptives. That one passed, I think, in 1972 with a different Supreme Court ruling. Anyway, also towards the end of the 60s, IUDs were invented. So all these non-permanent ways of prohibiting childbirth had a lot of huge social effects, obviously. Not for nothing, but over half this room is female. If you were subject to become pregnant, highly likely every time you had sex, hard to have a career when that's the case. So that's contraceptives. An interesting effect of in general of success is that it makes you less wary, and we'll come to this in a couple decades, is starting from 1910 with the syphilis antibiotic, then mass-produced antibiotics, and most sexually transmitted diseases or infections are treated by antibiotics. So from like 1910 to 1950, you have this proliferation of antibiotics. In 1960, you get oral contraceptives. So as far as we know, all the negative aspects of having sex are fixed and solved. So yay us. Way to go, humanity. Technology wins. That'll come to bite us in about 15 years, but we're not there yet. Also, we have the fourth attempt at nationalized health insurance. This is through the Johnson administration. JFK was it was a big project of his. He didn't survive to see it pushed through, and neither did Johnson because it wasn't pushed through. It was a failed first attempt. However, there was a big compromise. This is where we get Medicare and Medicaid from. Prior to this, it was just Social Security insurance, and that was only 30 years old. So the existence of what is now CMS comes back to this Medicare and Medicaid passing in 1965. Questions about the 50s or 60s? That was last session, but that was 1948. It was during World War II. Yep. But they made it systemic outside of wartime in 1954. Yep. And that was really the first big tax overhaul. Again, income tax as we know it didn't exist until about 1918. So basically there was this 30-year run or 40-year run, and then they decided maybe we should tweak income taxes. Incidentally, that's when they introduced the 90% top marginal wage bracket. So it's possible. On to the 70s. More of my terrible puns. There's another Cold War going on because there's still tons of money. And all these hospitals, there's tons of money, but there's a finite number of patients, right? There's a very strong case to be made that this is a similar parallel to what's going on with universities and tuition, in that there's tons of guaranteed income through federal grants and loans, and there are tons of institutions who want your money, but there's only a set number of college students. So what you do is you either increase the number of college students to get more money, or you get more and more bells and whistles onto your university to draw people's dollars. Exact same thing's happening here, just with hospitals instead of colleges, and with sick people instead of students, and with an economy full of federal money and individual money instead of cheap loans. And obviously, adding more bells and whistles drives prices up. But it's flush, right? And we're rushing. ERISA was passed. As an employee at a company, you might be familiar with ERISA. It does a lot of stuff. Basically, a lot of plans are structured, like your healthcare plans are structured under an ERISA umbrella. The only thing that matters here, especially, ERISA is the Employee Retirement Income Security Act, incidentally. It's what like your 401k and stuff is covered under. It mostly deals with retirement income, but there's a part of ERISA that says for union and single employer health plans, so this doesn't apply to our health plan because we get it through Blue Cross, but if we decided to self-insure and have a definitive healthcare health plan for you, we would not be subject to state, there are exceptions to this, but generally we would not be subject to state guidelines or state rules that govern health plans. So if Massachusetts said all health plans have to have this, if we had an ERISA plan, we could tell Massachusetts to go do what it wants with itself, and we would do what we wanted. Again, we wouldn't, we'd take care of you, whatever. Then there's the fifth attempt at nationalized health insurance with the Nixon administration. This is arguably the closest it's ever come to passing. Again, an interesting counterfactual in that Nixon was a very Republican president, but this was a big initiative of his. Because narratives get messy and history is messy. This also failed. Otherwise, we would currently have nationalized health insurance. But Nixon got a few things through. Were the relevant things are with the Social Security Act. Lots of things happened. It's actually the Social Security Amendment, because the Social Security Act itself passed in 35, whatever. So this amendment to the Act created the need for requirement for certificates of need, CONs, to be filed. So basically there's this gold rush going on, right? And hospitals are inflating. And so the worry is capitalism's phenomenal at creating results. It's also phenomenal at creating waste. So the worry is that all these hospitals are going to get so built up trying to get clients, and just by the nature of how competition works, there's going to be a lot of empty space, a lot of waste, a lot of overhead. Because if two hospitals are great and they're basically the same, but one's a little bit better, you have all the people go to the better one, and the slightly good or the slightly less better one is left empty. Again, an exaggeration, but that's a big problem, a long-term problem. Again, the market's really good at coming up with a solution, doesn't really think long-term. So that's the Social Security Act. It said, okay, if you want to build an improvement on a hospital, you have to submit a certificate of need and prove to us that you actually need that improvement. Eventually, that was a federal law, so all states had to do it. Eventually, that federal law was allowed to lapse, I believe, in 1983. Let me check. Nope, 1987. But some states, actually 35 states, decided to keep their own state version of a certificate of need. So not every state requires it, but the states that do basically got the template from this federal program, which in turn got the template from New Jersey, if you're interested. And also the HMO Act. This is a big one because it created the structure of HMOs. And it did a thing that government often does. It tries to test out an idea. And in order to do that, it relaxes regulations for the thing they're testing out. So if you create an HMO, HMOs are a health maintenance organization. It's a managed care scenario. And HMOs had different requirements than kind of your regular health insurance of what they had to cover and what they didn't. And they also, HMOs were originally set up as nonprofits. All HMOs were nonprofits. This also, incidentally, eventually was allowed to not renew, to pass. And I think that one was in the 90s. Let's say the 90s. Because the 90s ended up hating HMOs. 95. So that's what Nixon was able to do. Again, you'll notice that a recurring theme with this nationalized health insurance, these pushes, is that usually with every push, kind of it never happens, but we kind of walk away with a little bit more. And the federal government gains a little bit more control over the health insurance market. Questions about the 70s? Awesome. Awesome. So, on to part 4, bubbles and synthesis. So as you notice in the past 3 decades that we just covered, lots of growth and lots of money and lots of expenses going up for various reasons. Exponential growth, by definition, is unsustainable, and the party always has to come to an end at some point. Our party came to the end of the late 70s, and in the late 70s, we were hit by a recession that was the biggest recession since the Great Depression. And this was, 40 years after the Great Depression, give or take. So we tend to, you'll notice in these stories, about 40 years is the cycle. So depending on what you define as a generation, 1 or 2 generations, is the cycle for us to start repeating our mistakes. So we got hit by this recession, and the economy started, or the United States started to enter double-digit inflation. So you have inflation, meaning your dollar doesn't go as far, and wages stagnate. But the thing about the health insurance industry and the health industry in general is nothing else stagnated. If you look at charts, which we'll see in a little bit, about the growth of like costs of healthcare and costs of health plans, you don't see any recessions in there. It just grows every year pretty consistently. So again, it's not a traditional market, and that it's not really tied to anything that we would consider a market to be tied to. Also, as very subtly hinted at earlier, we start to see some repercussions of forgetting that there's more to sex than childbirth and bacterial infections. The HIV/AIDS crisis hits us, and for the first time, we are faced with a thing that we can't beat from a medical perspective. I mean, cancer's kind of always been around, so that wasn't a shock to our system. And we had ways of addressing cancer, but we didn't even know for years what caused AIDS. And the best we've been able to come up with in 30 plus years is to make it livable. So we've got that going for us. So anyway, that was kind of, in addition to inflation, in addition to wages stagnating, from a healthcare perspective, we are knocked off of our pedestal, off of our high of everything getting better all of the time and us having solutions for almost all of it. So now we start to buckle down and we start to say, okay, we can't just have a spending spree forever. Again, this starts around the early 80s. And here's where Medicare introduced its prospective payment system. This is where DRGs enter the fray. Again, when there's not a lot of money, fee-for-service gets kicked out. So instead of saying if someone was in the hospital for 5 days, you get paid for 5 days of hospital, they say if someone's admitted to the hospital for this DRG code, I don't care if they're there for 10 months, you're only getting this much money. So it's a cost-saving structure. One could argue it's also a quality improvement structure, but it's mostly just a cost-saving structure. There's also the Waxman-Hatch Act. So I talked a little bit ago about how part of what Nixon kind of got out of his push for nationalized health insurance was this change to allow actually, no, this wasn't that. It was a different one. Was the change that allowed generics to get past the kind of workaround of having someone just re-up their drug under a new name. But the powers that be looked and saw that even after having made that change a couple decades ago, there still weren't a lot of generics out there. So there's obviously something else wrong. And I want to get some numbers here. Yeah, in 1983, only 35% of top-selling drugs had a generic competitor, which again is not a lot. And for comparison, after this Waxman-Hatch Act was passed, a couple decades later, it was about 84% of leading drugs had a generic competitor. So what they did was they threw a bone to what they call them is the innovators or the producers, the people who come up with the new drugs. And they said, okay, so we will extend your patent. So it's the patent period plus the period that it takes for you to develop and test things. We won't count that against your patent. Seems fair? And the other element, what was it? Oh, and also there's the 5-year data exclusivity. So not only do you have this protection of the length of your patent, but you also have an exclusivity on data that the FDA gathers from this drug. So you're the first to know results of your drug, which is great. And the bone they threw to the generic producers is they streamlined the application process. And another thing they did was to eliminate a big barrier that was stopping generics from being produced, which is, in order to create a generic, what do? You take a drug that exists and you reverse engineer it. Problem with doing that is, as far as patent law is concerned, that's patent infringement. So a big producing, innovating company could find out that you're doing that and sue you and stop you from developing a generic. And that's totally in line with patent law. So the bone that this legislation threw to them is to say, while you're developing a generic, and you have to submit forms and stuff so that you're not doing it, on the sly, while you're doing this, you're immune from that kind of legal action. So that you can't be bullied by the big guys while you develop a thing to compete against the big guys. Does that make sense? Cool. So that's the 80s. A lot of terrible hairstyles too. Yep.
For the Medicare Act that went through, she said that it was a cost-saving structure for patients, not for the hospitals. Because I would assume if it was like focusing on DRGs and not fee-for-service, that the physicians would be like making less.
Correct. Yes, it was cost-saving for, and by patients, it's cost savings for payers, right? Because in the business side of things, patients are the product, right? So cost saving for payers, and the biggest payer is the government, right? Good. Other questions?
For the Wax and Hatch Act, what was the initial percentage that had generic?
In 83, it was 35%. Yeah, 35 to 85, I think. Yeah. And that's a big part of it. It was suing, and it was a hard process to go through, a combination of those two things. And so it was 35 of the top sellers of all drugs. It was 13% had generic counterparts. Others? It's fascinating stuff, right? It's funny. I think I might have said this last time, but it's interesting when people say our healthcare system is broken, because broken implies design, right? That's like saying your appendix is broken. Like, no, it's there. You just don't know why it's there, because it just grew there for some other reason at some point in history. It's just a thing. We're not broken. We're just evolved, and not in a good way. And again, the note up top is it just mirror there are a lot more old people, is another reason why we're starting to tighten our belt, is because if you do the math, people died young for a long, long time. We fixed that. And once people started to grow old, or to be able to grow old, or at least to not die young, they started to friggin' live longer. And in 35, the Social Security Act was passed, saying that if you live to 65, you should be good to go. And then on top of that, in 65, we passed Medicare and Medicaid, saying, at least for a Medicare perspective, if you live to 65, you're good to go. And then people started to live to 65. And that started around here. People born after the end of World War I, which had a big boom of births, started to live to this long. And we were like, crap, we actually have to pay this bill.
So we did it to ourselves.
Most things that are bad are done to oneself, aren't they? Yep. Also, not only are the old people staying alive, we have a lot of young people too, all of a sudden. The millennial generation is the biggest, other than, or maybe since, I think they might be tied, with the boomer generation. So we have a lot of old people who we promised to pay for, and we now have a lot of young people, some of them need paying for. So I'm skipping down a little bit here. So in 1997, they passed the CHIP program, or S-CHIP for state. And what that does is it's similar to Medicaid, and it's tied to Medicaid in many states, where individuals under a certain age, typically under the age of 18, are eligible for health care, for government health care, even if their family as a whole isn't eligible for health care. So again, inflation, stagnating wages, a lot more people under the poverty line than were just a decade ago. We have to take care of some of those kids who are falling under that. You'll notice this started around the 40s and 50s, but right around the 90s, it really hits its peak of legislation starts to be passed. Some of it expands benefits, some of it retracts benefits, and there doesn't really seem to be a lot of rhyme or reason to it. It almost seems, and this is all my opinion, obviously, but it almost seems like whatever can be passed gets passed, and there's no kind of overarching strategy to what gets passed. So we have HIPAA passes, which does a lot of things. Most people think of it as a privacy, the health insurance privacy thing, but it's actually more, it's a lot more than that. Privacy is only one of 5 parts of it. A big part of it is when you move jobs or change jobs or are fired, you get to keep your health insurance for a little while. That's COBRA. The HIPAA triggered that. So, there's all of a sudden this expense that's put on employers and on the state at a different level that they have to pay for this. And we're also paying for CHIP. And we'll talk about some of the belt tightening ones in a second. We have,
That's the first time, like 96 was the first ever patient confidentiality, any sort of.
Yeah. Well, it's interesting. I want to mention this, and when we're talking about the Medicare prospective payment system, again, it's really important to keep historical context in here because not only did this pass in 1983, which is obvious because I wrote it up there, but this really couldn't have passed in 78 because this kind of system requires computers. It requires the type of filing and the type of submission that just can't be done with paper files. So not only is this stuff happening in real time, it's also partially, it's only happening as it's able to happen. So similar to HIPAA, right? How old is the internet in 96? It depends on your definition, but it's only in the widespread culture by about 4 years, let's say. So transmitting patient data wasn't a thing. And fax machines had only been around, 10 years, let's say. Probably not that long. Fax machines had only been around for 10 years. So yeah, 96 is the first time because 96 is, guys, 96 technologically might as well have been a different world than today. I don't know. I was about to say, I'm not gonna ask how many people were or weren't alive at what age in 96, but it might as well have been several lifetimes ago from a technology standpoint. So, yes.
Other questions?
What else was in HIPAA besides the insurance and the patient?
That's a great question. I'll tell you. Let's see. Yep, so the first one is the COBRA effect. The second one is the Privacy Act, so electronic health records and how they need to be handled. The third starts to establish, this is a thing we'll get into in the next slide, but starts to establish tax guidelines for tax-free medical spending accounts, like FSAs and HSAs, stuff like that. And part 4 sets the guideline for group health plans. So the ones that aren't single employer that I talked about, that we get to kind of do whatever we want, but the ones that are group health plans like ours, but that are facilitated through a mediator, sets guidelines for what is and isn't acceptable for those, and also tax guidelines as well. And then Title V does the same thing, but for company-owned insurance programs. So again, HIPAA, we think it's privacy, or at least if you know about it, you think it's privacy, but that's really only one part of it. Other questions? Cool. Still in the 90s. So not only do we have a lot of people living for longer and a lot of people being born, but we get to start dealing with all the health problems that come around from living longer and from living in a country that's still doing relatively well. And whereas a lot of illnesses that kill you young can be solved with vaccines and antibiotics, the illnesses that kill you old are very complicated because for lots of reasons. Typically, when you die young, all of your bad choices of 40 years don't have time to catch up to you. So that's what this more or less indicates, is obesity skyrockets, diabetes skyrockets. We're not even going to talk about mental health. That starts to hit in the 90s and really ratchets up in the next decade. But a lot of long-term trends, things that aren't solved by a vaccine, happen. So the 90s is rough, guys. Also bad hairstyles. Actually, more bad clothing styles. It was all about baggy clothes. Everyone looked bad, but we all thought we looked cool. Nirvana? What are you talking about? Oh, all right, we're not getting into. I was the grunge kid too. Although late 90s, I was more punked with like spiked hair. Yeah, I outgrew that shit. So other things that are happening in the 90s, mergers and acquisitions are happening like crazy. Again, it's largely a cost-saving feature. Also, there's no longer a doctor shortage. That was in the 60s, we'll say, and every mother has told their son to be a doctor. So great. Now there's a massive nursing shortage, and we're not in as big of a nursing shortage, but we're still in a nursing shortage. Also, consumer-driven plans evolved. So they started out as, or rather, they were introduced. They started out as MSAs, medical saving accounts, in '93, and then they later evolved. We'll talk about that in a second. Managed care, those HMOs I was talking about, all the rage. Again, it's kind of the pendulum of fee-for-service, managed care, fee-for-service, managed care. When there's not a lot of money, you want managed care because it's using every dollar intelligently, or at least more intelligently. So HMOs are introduced everywhere. Medicaid basically folds all of its services and vendors into HMOs. And that's the idea, is to contain costs. That only lasts for about 6 years until everybody collectively agrees that HMOs are the worst. And I only just got over this like 4 years ago. Like up until 4 years, I had this inexplicable bias that HMOs are the worst thing ever. But that was because that was a holdover from what I learned in '98. So basically, HMOs were in and then they were out for fair reasons. And this is when the HMO Act of '73 was allowed to lapse. They don't get the perks that they got anymore. Part of the HMO Act of '73 was, if I as an employer am offering a non-HMO plan, so we'll say a PPO, if I'm offering that, I have to offer an equivalent HMO plan. At least until '98 or whatever, till this was allowed to lapse. Yeah, so between HMO and a PPO, is that what you're saying? So a PPO it's kind of the fee-for-service equivalent of providers. You basically, as long as a provider's in a network, you can go to whatever provider you want. You're paying just a copay, and it doesn't matter. None of your providers have to talk to each other. You just go. So basically, the healthcare is in your hands. With a HMO or managed care, you have to have a primary care physician, and basically all medical procedures go through that person first. So you can't even get authorization to go see or at least you won't get reimbursed to go see a specialist without your primary care physician knowing about it. The networks tend to be, especially in the '90s, tended to be a lot smaller, just because it's hard. Negotiating is hard and mass coordination is hard. At least in New England, HMOs and like our plans, HMO and PPO are relatively equivalent. But outside of I mean, outside of places near major metropolitan areas, HMOs are tough because if you have a couple cities nearby, it's not that hard to find a doctor in your network. If you have 2 doctors in your town and the next town is 40 minutes that way and neither of them are in your HMO plan, that's a lot tougher. So if you're ever interested in taking a temperature, HMOs are still pretty unpopular in the central and southern or southeastern United States. Other questions? And 1990s, everything is getting more expensive, but pharmaceuticals are going crazy. This is the I can't think of the name of the movie. There's a lot of good movies about like the pharma boom and being a salesperson. Then there's one I forget. It's what's his face from Donnie Darko, Jake Gyllenhaal, Love and Other Drugs. Yeah, when they like discover what the hell is it called? Yeah. It doesn't matter. It was basically in the 80s you wanted to be an investment banker. In the 90s you wanted to be in pharmaceuticals. I guess that's the analogy I'm trying to drive home. So because costs are skyrocketing, Medicaid imposes rebates. And I made a note here. This is the epitome in my mind. This is the perfect example of kind of the evolved, we'll say, nature of our system. In that, okay, so Medicaid is done state by state, but also kind of legislated centrally. So that's a fun thing. It says, in order to, for this, you drug company, you Pfizer, in order to participate and get reimbursed through Medicaid in this state, you have to sign up for a rebate program. Basically, if we use your drug, then you send us some extra money, and then we'll send you how much we owe you. And if you don't agree to this, you can't sell drugs at all, or at least you won't get reimbursed at all through Medicaid. It's just this weird amalgam of private and public and state and federal all working together, but kind of not at all really. And introducing a series of transactions instead of one transaction or two. So Medicaid imposes this across all states and across all pharma vendors. PBMs, pharmacy benefit managers, those started in the 80s, but they really, again, a rising tide lifts all boats or whatever. So PBMs become very big in the 90s. I have some fun statistics here. So by the end of the 90s, you know, I forget the government agency that determines whether or not something's a monopoly, said that the PBM market was totally fair and equal. By 2013, there were only 60 major PBM companies. By 2016, so 3 years later, there are only 30 major PBM companies, and only of those 3 control 78% of the market. So those 3, incidentally, are Express Scripts, CVS Health, and Optum Rx. All of which are not even independent agencies. One is tied to a drug chain store, CVS. One is tied to United Health Plan, and the other is tied to something else. Yep. And then there's direct-to-consumer drug advertising. So this is, again, habitual now. We're super used to it. These really didn't exist until the mid-90s. Do you guys want to watch a couple commercials? Okay. I was hoping you'd say yes. So here's the first direct-to-consumer commercial. As you'll notice, this is in '83. This is before the 90s. And this is the first recorded television commercial, and it will become evident why.
If you're one of the many people who take the prescription drug Motrin, you should ask your physician or pharmacist about Brufen. They will tell you that both Motrin 400 milligram tablets and Brufen 400 milligram tablets are different brand names for the same drug, ibuprofen. There is only one important difference. Brufen can cost you considerably
And that is the commercial. So there was no, again, that was a new thing. And that was 83. That was first happened on television. There was no regulation or anything like that. So it wasn't a big deal, but around the early 90s, especially 1991, all of a sudden commercials like this were everywhere. And so the FDA said, okay, hang on a second, or is it SEC said, hang on a second. And it put a kind of a temporary moratorium on commercials. And then while the legislature figured out what the rules should be for these, the SEC said, okay, you can have pharmacy commercials, but you can't, taking a step back, pharmacy advertising was allowed, just not on TV. And the only reason it was allowed is because it came with a lot of fine print that came with the package that you were sent. There's these little booklets, you've seen them before, they come in your drugs right now. And because you couldn't do fine print on a commercial, it's not allowed because it doesn't follow the rules of other advertising. So the workaround from 91-ish until 95 or 94 was you can advertise your drug, but because you can't do small print, you can't say what your drug does. And also, you have to mention in your commercial the generic equivalent of your drug. Here we go. Incidentally, if you do like YouTube old prescription.
You know, a lot of them want to know more about Rogaine with minoxidil. If you're one of them, I have good news for you. Now there's a video prepared especially for men who want answers to their questions about Rogaine. Simply call 1-800-477-8996, and Upjohn will be glad to send it to you, absolutely free. Now, once you've looked at it, you'll probably want to schedule an appointment with a doctor. After all, only your doctor can prescribe Rogaine. And if you call right now, Upjohn will also send you the names of doctors in your area who can help you decide if Rogaine is right for you. You'll also receive a $10 certificate as an incentive to see your doctor. For your free videotape that gives you the complete story on Rogaine with minoxidil, and your $10 certificate, call toll-free 1-800-477-8996. So what are you waiting for? Make the call today.
That's almost as ambiguous as head-on.
Yeah, like what the hell, right? We all now know what that means, and so we can interpose. But like, yeah, his hair. Yeah, but like nowhere does it say what the hell they're talking about. There's like, are you interested in this thing that I can't tell you why you might be interested in it? That also, it's incidentally, you could get it for cheaper because it's called minoxidil. Well, in that case, call your doctor and we'll send you this thing that has fine print that will actually tell you what it's about. So it was an advertisement for an advertisement. It was good times. And $10. So that's direct to consumer. And yes, Saturday morning cartoons were ruined forever. And I'm not going to explain to you guys what Saturday morning cartoons were, because that's a whole different thing. All right, so that's the 90s. The 90s got a lot of slides because a lot of things were happening in the 90s, most of them not great. So in the aughts, in our defense, we didn't think we'd live this long. So things continue to come apart at the seams. This is a slide I was telling you about where I don't see a dot-com bubble burst or a 2008 recession here in the prices. They just go up. And these are the sticker price, or the premiums without your employer helping out for family plans and individual plans for health insurance. So this is evolving quite a bit. Not a lot of legislation was passed in the aughts. Our national attention was fixated elsewhere. We, had multiple wars going on. We had 2 bubbles burst. We had other things going on as well, obviously. We tried to pass a Patient Bill of Rights Act. Ted Kennedy and John McCain tried to pass that, which basically just outlined basic things that all patients are entitled to from their doctor. Couldn't get it passed. So that's kind of the legislative malaise of the aughts. Consumer-driven plans evolve, and by evolve I mean largely change names, but they don't change that much. Medical savings accounts become consumer-driven health plan accounts, become health savings accounts. Again, all the idea is you can spend money tax-free as long as it's on healthcare. So you can kind of see the market is more or less giving up and just saying, well, you figure it out. We tried HMOs, you didn't like that. Costs are going up, but you figure it out. Medicare Part D passed, as all of you know who have attended my Medicare session. That's the one that covers a lot of drugs. Before then, the only drugs that were covered under Medicare were doctor administered drugs, like chemotherapy, stuff like that. And at the end of the aughts, we have 47 million individuals uninsured. That is about 16% of the US population. Rough year for healthcare. Then in the 2010s, it's all about the Affordable Care Act. Basically, nothing happens in the 2010s that isn't one way or the other the advancement of or reaction to the Affordable Care Act. There are no healthcare discussions that are independent of that piece of legislation. It's basically the biggest healthcare legislation since Medicare and Medicaid were introduced in 1965. And again, we have a whole other session on the Affordable Care Act, so I'm not going to go into details, but it had two purposes. One was to change the insurance industry, which was getting more people access and making sure coverage was better, and then to change the actual healthcare industry to improve outcomes and digitize things and make things more seamless. The introduction of a lot of our quality scores that we track, like HCAHPS, those start with this. The implementation timeline for the Affordable Care Act was in 2013. Health insurance exchanges go live. That allows people to comparison shop between health plans, a relatively new thing. And again, a key factor of a market is allowing people to compare things. And then most provisions go into effect, including the individual mandate, which requires everybody to have health insurance or pay a fine. That goes into effect 2014. And then ostensibly the Cadillac tax, which taxed people, you know that workaround where employers don't have to pay taxes on health insurance. It basically said, yeah, but you can't give them like $50,000 a year health insurance. Otherwise, you're going to get taxed on that. That's the Cadillac tax. Of course, that was as it was passed in 2010. Things happened throughout the teens that affected and changed the original Affordable Care Act. There were the Supreme Court decision of NFIB versus Sebelius. That's the one that said with the Medicare expansion, states don't have to participate in the expansion in order to participate in Medicare. Again, that's part of the Medicare Medicaid discussion. But it basically said this attempt that you have to increase the number of people who have insurance, you can't force it down states' throats. Burwell versus Hobby Lobby pushed back on the concept of making sure insurance covered certain things mandated at the federal level. It said that certain closely held corporations don't have to offer certain types of, in this instance, contraceptives. And then in 2016, we got a new president, one that didn't pass the Affordable Care Act. And the Consolidated Appropriations Act basically said, that Cadillac tax that's supposed to be happening in 2 years, that's not going to happen anymore. And in 2017, the Tax Cuts and Jobs Act, which if anybody's filed their taxes or received their tax returns this year, have already seen the effects of, that said that individual mandate that was kind of one of the foundations for the Affordable Care Act to work financially, that's not required anymore. And that leads us to today. I'm not going to belabor this, but this is kind of where we're at right now as far as the results of the Affordable Care Act are concerned. About 9% of the population is uninsured, down from that 16%. Going forward, it's going to be somewhere between 13 and 10% because of the change to the Medicaid expansion and to the removal of the individual mandate will probably bump up how many people are uninsured, although mostly due to their own choice. This graph shows, let's see, average annual growth rate for select service types, so hospital, doctor, and pharmaceutical, I believe. As you can see, the growth rate has gone down. This is per enrollee spending growth on public insurance, so Medicare, Medicaid, healthcare, or rather private insurance, healthcare, Medicare, and Medicaid. So Medicaid dropped down in the aughts, and then everything else is growing more slowly. Still growing, and as this chart shows, growing above the rate of inflation, but not as high above the rate of inflation as it was during the 80s, 90s, and aughts. So instead of all the rooms in the house being on fire, only the kitchen's on fire. So we've got that going for us. So again, back to the narrative. We figured out what the hell a cell is and a bacterium is, and people lived longer. We figured out how to get healthcare efficiently to individuals, mainly by killing individuals and having to figure out the repercussions of that. We survived wars and became the only surviving power, basically, and so we had lots of money, and so we spent that money because that's what you do when you have lots of money. And then after the party was over, we were left holding the bill, and we're trying some things whenever we're not distracted by other problems that we're putting on ourselves. And we're left in a situation now where, again, only one room of our house is on fire. We only have about $1 trillion deficit. And again, a deficit means that's added every year to the budget deficit. The budget deficit is added to the debt. So $1 trillion each year, our debt's growing by $1 trillion each year, and our deficit is $1 trillion each year. And more and more people are growing old and not dying because we're getting better at healthcare. So good for us. So we get to keep covering those people who just refuse to die, whom 2 of them are my parents, I love. We keep covering them, and there aren't a lot of people paying into the system, so we're making up with borrowed money. When one of our biggest lenders, we're flirting with a trade war. So have a great Wednesday, everybody. That's where we're at so far in U.S. healthcare.